moving on to chapter 16. We're going to start with antacids. This chapter is all about gastrointestinal drugs. Antacids are exactly what they sound like. They cut down on the amount of acid that's present in the stomach. Too much acid can cause abdominal discomfort, a little bit of pain, and just be generally kind of an uncomfortable experience for the patient. So antacids work for pyrosis and dyspepsia, any of that, sort of indigestion you might feel after you eat a big meal, or if you're stressed out or eating things like chocolate or caffeine that can irritate the stomach. Antacids neutralize gastric secretions. Usually they'll contain aluminum, magnesium, calcium carbonate, or sodium. And there's a ton of different options out there on the market, many of them over the counter, most of them over the counter. So it's kind of trying to figure out what works for each individual patient. Side effects are usually constipation, especially with aluminum or calcium salts, and diarrhea with magnesium salts, electrolyte imbalance, urinary stone formation, osteoporosis, which occurs with aluminum salts, and also belching or flatulence found specifically with calcium carbonate and sodium bicarbonate. You want to be careful using these medications in any patients with heart failure, kidney or liver disease, as well as dehydration or electrolyte imbalance. Interactions. Antacids can kind of interfere with the absorption of many other meds, so they have a ton of interactions. Generally, they recommend that you separate antacids out from other medications by about 2 hours before or after giving the antacid. You'll especially notice this with digoxin, indomethacin, iron salts, thyroid medications, salicylates, medications for osteoporosis, any enteric-coated drugs, and many others. So usually if they're on an antacid, they're probably going to have an interaction with another med they're taking. Next, they move on to drugs for the treatment of gastroesophageal reflux disease, which is constant. It's a chronic disease, constant reflux from of the gastric secretions coming back up into the esophagus. It's very irritating. It can cause pain and almost chest pain, actually, as well as pain when somebody eats. So we generally treat that with H2 blockers or PPIs. H2 blockers block histamine receptors in the stomach lining, and those are the receptors that cause the release of gastric acid. So if we block them, we cut down on gastric acid. They're used for short-term relief of indigestion, GERD, esophagitis, and prevention of duodenal ulcers. Generally, if they're given with the PPIs that we're going to talk about in a minute, H2 blockers are given at night and the PPI will be given in the morning because they do interact with each other. Side effects of H2 blockers: diarrhea, rash, dizziness, and headache. One medication they mentioned, cimetidine, which isn't used too frequently, can cause gynecomastia, which is, again, enlargement of breast tissue in males. Usually that is rare and reversible once the person stops taking the medication. Especially in the elderly, famotidine can cause confusion. Usually we recommended lower dose in the elderly because their kidneys don't function as well, so they can't get rid of it as well. So we want to be careful in patients who have kidney disease, as well as patients who are pregnant or nursing. And interactions, again, there's a ton because we are messing with the pH level in the stomach. So it will interact with warfarin, phenytoin, beta blockers, benzodiazepines, lidocaine, theophylline, tricyclic antidepressants, and PPIs. A lot of those medications I mentioned up front are really important. Warfarin is for blood, thinning out your blood. Phenytoin is for seizures. Beta blockers are for blood pressure. So when we talk about giving these medications, we want to be careful to make sure we're not exposing this patient to interactions which will make their very important medications not work so well. Next up for GERD is proton pump inhibitors, and these are usually used, they're a little bit more potent and they work better. However, they're not to be used for long-term relief unless the patient is under doctor supervision. So if left untreated, gastroesophageal reflux disease can lead to stricture of the esophagus, which is basically closure, as well as aspiration, which can lead to pneumonia, and cancer in the long run. So we want to make sure that these patients are treated and that we keep an eye on them. So PPIs are proton pump inhibitors, and they also cut down the amount of gastric acid that's in the stomach. You might have heard of pantoprazole or Nexium, which is esomeprazole. Again, there's a bunch of different options out there. It's just a matter of finding one that the patient responds well to. So side effects: diarrhea or constipation, nauseousness, vomiting, and abdominal pain. increased risk for intestinal infection or pneumonia, as well as a possible risk of vitamin B12 deficiency. It can also lead to low magnesium levels with prolonged use, as well as osteoporosis in the elderly, because it can mess with absorption of calcium. Interactions. The biggest one you'll hear is Plavix. Plavix, which is the generic is clopidogrel, interacts with a few of the different PPIs. It does not interact with lansoprazole, which is Prevacid, so generally that's the PPI we'll recommend when a patient needs to be on Plavix, as well as something for gastroesophageal reflux. They also interact with H2 blockers, sucralfate, benzodiazepines, phenytoin, and warfarin, as well as some different antibiotics and medications for osteoporosis. Some of them you're required to give on a full stomach, or on an empty stomach, and some of them do not have any regard to administration with meals. Generally, pantoprazole or Protonix and rabeprazole or Acefex can be given without regard to meals. Everything else is usually given first thing in the morning, about 30 minutes before the patient eats. Antispasmodics, and those are medications that are going to prevent the stomach from spasming, which can be painful. I think I skipped over a whole section, gastric mucosal agents, as well as Helicobacter pylori. We won't focus on those too much. You don't see those medications used too often. So on to antispasmodics. The big one they're giving you an example of here is dicyclomine, which is an anticholinergic. Dicyclomine is used to help calm the bowel in somebody who has an overactive bowel. So irritable bowel syndrome is generally the term you'll hear used there. So anticholinergics, if you remember correctly, dry up everything. So let me move on to this. We are talking about dry mouth, constipation, blurred vision, drowsiness, dizziness, and this is especially increased in the elderly. So we want to be careful with this medication in anybody who is 65, 70 and over. And we also want to be careful in patients who have glaucoma, unstable cardiac disease, any GI obstruction or ulcerative colitis, BPH, which is benign prostatic hyperplasia, or myasthenia gravis. Antispasmodics such as dicyclomine can interact with phenothiazines, which is promethazine is probably the most common one you'll know of, tricyclic antidepressants, and opiate agonists. Agents for inflammatory bowel disease. And inflammatory bowel disease is a chronic condition that causes inflammation of the lining of the gastrointestinal tract. You might know it better as Crohn's disease or ulcerative colitis. It's a very painful condition and can lead to diarrhea or constipation depending on the patient. So generally we want to relieve those symptoms and make the patient's life a little better. Salicylates are our first drug that we're going to talk about. Specifically, options there are mesalamine or sulfasalazine. These medications come as oral or even rectal enemas. So there's a couple different options there when treating these patients. Side effects of these medications include anorexia, nausea, vomiting, diarrhea, and dyspepsia, abdominal cramps and bloating, headache, weakness, dizziness, and rash. We want to be careful in anybody who has an allergy to salicylates, a sulfa allergy if we're talking about sulfasalazine, or a sulfite allergy, and anybody who has renal or hepatic impairment. These medications interact with warfarin, methotrexate, cyclosporine, some oral diabetic agents, and folic acid, as well as glucocorticoids. Antidiarrheal agents. I'm sorry, let me go back there. Glucocorticoids is an entirely different subject there. Glucocorticoids are also used to treat inflammatory bowel disease. If you remember, they are anti-inflammatory, so they help bring inflammation down. They're covered in a different chapter, under chapter 23, which I think is something we'll be talking about in week 8, if I remember correctly. So antidiarrheal agents. Sorry if I'm rushing through this, trying to keep it under my 15-minute time limit here. Antidiarrheal agents, many of you are probably familiar with because they're all over the counter. Pepto-Bismol or bismuth subsalicylate. It protects the stomach, it coats it. It also prevents secretions, and it's sort of a weak antacid and weak anti-inflammatory. So it does a number of things, which is why it works so well for many different problems. Side effects: it can cause constipation, discoloration of the stools, it can turn them black or gray, as well as ringing in the ears. Because it's coating the stomach, it can interact with quite a few things as well. Warfarin, aspirin, methotrexate, just to name a few. We want to be careful in anyone with salicylate allergy. We generally don't use it in children under 12. There's a special formulation of Pepto for children under 12. Anyone who has coagulation abnormalities or is pregnant or lactating. So our next option for antidiarrheals are opiate agonists. Diphenoxylate with atropine, which is called Lomotil, or loperamide. Generally, Lomotil is sort of an anticholinergic. It can cause drying of secretions, drowsiness, urinary retention, blurred vision. So again, we're always going to be careful with that medication in the elderly. Both medications can cause abdominal distension as well as nausea or vomiting. And here we want to not use these medications in patients who might have diarrhea due to an infection such as C. difficile. We want that patient to be able to get that bacteria out of their system, so we don't want it sitting in their gut. We don't want to prevent the diarrhea, I guess is what I'm saying. We also don't use it in young children or anyone in which their diarrhea was caused by infection or poisoning in general. We also don't use it in pregnant patients, and we try to avoid it in the elderly if at all possible. Probiotics, you guys are also probably pretty familiar with. They're basically just adding good bacteria back into the gut, especially if somebody has wiped it out with an antibiotic or maybe just doesn't have a good diet to kind of encourage that good bacteria. Antiflatulence, aka anti-gas medications, break up gas bubbles in the intestines. The most common one would be simethicone. Not a ton of side effects with that. You take it, it works. It's very simple. Laxatives and cathartics. Again, you guys are probably pretty familiar with all of those. Bulk-forming laxatives or fiber supplements absorbs water back into the stool or the GI tract, helping to increase fecal mass and move things right along. They take a little longer to work, about 12 to 72 hours, so if we're looking for an immediate response, that's not our first option. We also don't use it in cases of partial bowel obstruction because we don't want to force a whole lot of mass into something that is obstructed. Stool softeners such as Docusate, they act as detergents to kind of moisten stools and to move them along. Again, 12 to 72 hours. This is a drug of choice in pregnant or nursing women. Side effects are rare. It's generally pretty benign medication. Emollients soften and coat stool. An example would be mineral oil, usually effective pretty quickly, 6 to 8 hours. We want to be careful in bedridden or geriatric patients or anyone who has difficulty swallowing. When you give mineral oil to someone, if they swallow it and they aspirate it into their lungs, it can cause aspiration pneumonia, which can be pretty deadly to somebody who's bedridden or an elderly patient. Saline laxatives, for example, milk of magnesia, they promote the secretion of water into the intestinal lumen and should be used infrequently and only in single doses. Generally, they work pretty quickly, about a half hour to 3 hours. Side effects include electrolyte imbalance, edema, cardiac, renal, and hepatic complications. And again, we want to be careful not to use those too often. Stimulant laxatives such as senna, castor oil, or bisacodyl, they produce GI muscle contractions, so again, they're moving things along. They take about a quarter of an hour to 8 hours to work, so pretty quick. And again, we don't want to do prolonged use with these. We also avoid them in children and pregnant women. Osmotic laxatives, these are your polyethylene glycol. The bowel prep is pretty common osmotic laxative. Can take 24 to 48 hours to work, so again, this is over time for people who are on it every day. Chloride channel activators, this is a newer medication, lubiprostone or Amitiza. As long as the patient doesn't have a partial bowel obstruction, we can use this medication as a last sort of option to help anybody with constipation. It increases intestinal fluid secretion by activating specific chloride channels in the intestinal epithelium. Usually takes about a day to work. I'm going to stop here and move on to the next video, which will probably start on chapter 17 as well.